Hi students, this is Dr. Tatum. I'm going to start back up on slide 9, and we were talking about the Doppler blood flow analysis. So the Doppler blood flow analysis is used to just give us more information about the blood flow and resistance in circulation. And so we use this in high-risk pregnancies that suffer from hypertension, intrauterine growth restriction, diabetes, those that have multiple fetuses present, and also preterm labor complications. And so basically, we can see abnormal results in poorly perfused placentas, in genetic disorders such as trisomy 13 and 18, from autoimmune disorders like lupus, and also from exposure to nicotine. We also look at the amniotic fluid volume because that can tell us a lot about fetal disorders as well. So there are a few terms that are going to be new. They are in your book, and they're also on the notes section of this PowerPoint. So the term called oligohydramnios just means low amniotic fluid. And so usually there's a fluid pocket that's less than 2 centimeters. And this can indicate congenital anomalies. It might mean that there is renal agenesis present, which is when one or both kidneys fail to develop properly. It also can mean intrauterine growth restriction, or it could also potentially indicate fetal distress when the patient goes into labor. We also use the term polyhydramnios, and again, this is on the notes section of this PowerPoint and also in your textbook. Polyhydramnios just means excessive amniotic fluid, so too much. So the fluid pocket is greater than 8 centimeters, or there might be multiple large pockets of amniotic fluid present on ultrasound. Polyhydramnios then could specifically indicate neural tube defects or an obstruction of the fetal GI tract. It could mean multiple fetuses, or it could mean accumulation of fluid in 2 or more fetal compartments on ultrasound. So when we think about what is considered normal, we use the amniotic fluid index. And so a normal level is anywhere from 10 centimeters to 25 centimeters. A low normal is anywhere from 5 to 10 centimeters. A low is less than 5 centimeters. So this would be your oligohydramnios. And then your high would be greater than 25 centimeters, and that would be your polyhydramnios. And so that is why we use and assess amniotic fluid levels, because that just tells us a little bit more about fetal conditions present. And then last but not least, we also do a biophysical profile. A biophysical profile assesses the fetus on many different levels. So we look at amniotic fluid volume again. We also assess fetal breathing movements in utero through ultrasound. We assess fetal movements in general. We also assess fetal muscle tone, because that's going to give us an indication on how mature the central nervous system is. And then we also assess fetal heart rate by hooking her up to an external monitoring device by doing a non-stress test, which we'll talk about here in a little while. So a normal score in a biophysical profile is anywhere from 8 to 10, assuming that she has normal amniotic fluid levels. And there is a page in your textbook that I'd like you guys to look at. On page 568, table 19-2 is going to give you a little bit more description about how they score a biophysical profile. All right, so we're going to move on. You guys can read about MRI on your own. I'm not going to go through that with you. And we're going to start with an amniocentesis now. So usually we do an amniocentesis to obtain amniotic fluid. And this amniotic fluid basically contains fetal cells that can give us some good indication about genetic disorders that might be present. We can assess fetal lung maturity and also for the presence of hemolytic disease in the infant. So this is performed after 14 weeks gestation. And what happens is we use ultrasound, and a needle is inserted into the abdominal cavity into a pocket of amniotic fluid. And amniotic fluid is withdrawn into a syringe and then sent to lab to be analyzed. And throughout the procedure, we're monitoring mom and we're monitoring the fetus. And again, throughout the procedure itself, we're using ultrasound as well. So we look at advanced maternal age. That might be something that we do an amniocentesis for. We also do an amniocentesis to check for any genetic disorders or chromosomal anomalies, especially if there is any family history of genetic disorders or chromosomal anomalies like Down syndrome. We can also use it to assess fetal lung maturity. And so a lot of times we're really specifically looking at the LS ratio, and that's going to tell us a lot about surfactant production. And then we can also assess for hemolytic disease, like I had mentioned before. All right, I'm going to keep moving on. There's a good picture in your book, and it's also on this slide, although it's kind of blurry, that shows what an amniocentesis specifically looks like. There are a number of maternal complications that can occur. So you can see here hemorrhaging, infection, it can induce labor, it can lead to a placental abruption, it can damage the intestines or bladder, and it can also cause an amniotic fluid embolism. I would say a lot of these complications are rare, but they still have to be discussed with the patient. So the patient needs to have an empty bladder. She has to assume a supine position, and she cannot move during the procedure. Baseline vitals and fetal heart rate is taken, and then the nurse monitors her vitals as well as fetal heart rate and uterine contractions throughout the procedure. She is told to rest for 30 minutes after the procedure, and if she is Rh negative, she needs to have Rogaine given to her afterwards. So she is hooked up to an external monitoring device to really do that continuous fetal heart rate monitoring and contraction pattern monitoring. Here, this next slide, you can see the fetal complications. So death, hemorrhage, infection, miscarriage, and also leakage of amniotic fluid are all specific complications that can occur with a procedure like this. I wanted to share with you that I did have an amniocentesis done with my first pregnancy. My son Wyatt, he just was not moving at all. And he didn't move a lot throughout pregnancy. And as pregnancy progressed, I got more and more concerned. He was breech as well. And then I developed gestational hypertension. So my blood pressure got pretty high. And because of that, I was in the hospital. And I was in the hospital 4 days before I actually had him. And during that time, I had an amniocentesis done. It was a little concerning just because he wasn't moving, and I was really worried about how mature he was. I was 36 weeks when I was admitted into the hospital, and then I had a C-section done at 37 weeks. The procedure itself was actually pretty fast. I couldn't move during the procedure. I couldn't take any large, deep breaths because they didn't want the pocket of fluid to move and we didn't want baby to move. It did sting a little bit because the needle is fairly large going in. And so that was really the only thing that I remember being a little concerning, I guess, about the procedure itself. But otherwise, it went well, and it ended up being that his lungs were mature, so they could take him at 37 weeks gestation. So it is really nice that we have this tool available to us in case of these high-risk complications. If these high-risk complications occur, then we can get baby out in order to just make baby more comfortable and intervene properly, and also to make mom more comfortable as well. All right, let's move on and talk about chorionic villus sampling. So this is a genetic study. Oftentimes we do this in the first trimester as an alternative to an amniocentesis. We can diagnose abnormalities much earlier because we can do this in the first trimester. The big thing is it cannot detect any neural tube defects like spina bifida. So this cannot detect that. But it can detect other abnormalities. And so what they do is it can either be done transcervically or transabdominally. So they can go through the cervix up into the uterus, or they can do it through the abdomen. And they remove a small tissue specimen from the fetal portion of the placenta. And basically, they aspirate this tissue using a syringe. And so basically, the type of tissue that they take is the genetic makeup of the baby. So they can tell a lot by this. And again, we can assess for any chromosomal anomalies, but again, we cannot assess for spina bifida or any neural tube defects with this. Post-procedure, there could be some vaginal bleeding that occurs, any cramping, we have to monitor. If she has any discharge or odor that could indicate infection, we need to notify the doctor right away. And the big thing is we do worry about miscarriage with a chorionic villus sampling, just because it's early in that first trimester. And so it's something for her to understand before the procedure gets started. All right, moving on to the next slide, percutaneous umbilical cord sampling. Basically, this gives us direct access to fetal circulation. What they do is they insert a needle directly into the fetal umbilical vessel. It's usually the vein under ultrasound guidance. So it's usually punctured. The umbilical cord is usually punctured near its insertion site into the placenta itself. That is where the cord is well anchored. They don't worry about the cord moving as much, and the risk for maternal blood contamination is very slight. So basically, a small amount of blood is removed and tested, and we call this the Klein-Hauer-Becky procedure. So basically, we take that blood and we can analyze it for any chromosomal disorders, any genetic testing that we need to do that could detect malformed fetuses. It can also detect fetal infection, and it also helps determine acid-base balance in a intrauterine growth-restricted fetus, so an infant that's not growing well. It can also be used to diagnose anemia. It can also be used for a fetal blood transfusion. So if the fetus is very anemic, we can give blood transfusions this way. All right, so moving on to alpha-fetoprotein, so a maternal assay. So basically what we do is we analyze the maternal serum levels of the alpha-fetoprotein to detect any neural tube defects. Usually neural tube defects are considered present if alpha-fetoprotein levels are high in mom's serum. So 80 to 85% of open neural tube defects and abdominal wall defects can be detected early through alpha-fetoprotein sampling. It's recommended for all pregnant women. Here you can see that trisomy 21 is associated with lower than normal maternal fetal alpha protein levels as well. So this is usually done at 15 to 20 weeks gestation. Alpha-fetoprotein is produced in the liver, and it's detected in the serum of pregnant women between 14 and 34 weeks gestation. So basically, this is a great screening tool that helps us to detect neural tube defects early, if possible. All right, that's all I'm really going to say about this test. We're going to move on and talk about the Coombs test. The Coombs test is used for detecting Rh incompatibilities. So it screens for different antibodies for incompatibilities with maternal antigens. So here's where we get kind of concerned about Rh factor here. So if mom is Rh negative and baby is Rh positive, the direct Coombs test can help us identify this incompatibility. It also is used to help detect the severity of fetal hemolytic anemia as well. All right, moving on. Antepartal assessment using electronic fetal monitoring. So there's lots of indications why we would do electronic fetal monitoring. Oftentimes in the first and second trimester, it's used to help diagnose fetal anomalies or uteroplacental insufficiency, so not enough blood flow getting to the placenta. And then in the third trimester, it's used to determine if the intrauterine environment is supportive of the fetus. So is the baby able to thrive in that third trimester? Is it getting oxygenated and perfused efficiently? The things that we use electronic fetal monitoring for is to assess fetal heart rate and also uterine contractions, which you guys know about. And so we're going to talk about this a little bit more in detail here in a minute. I see that my time is about up, and so I'm going to stop here and then I will start again and we'll talk about fetal responses to hypoxia and asphyxia.